Thanks very much, Karen. Mary and I are both delighted to be here today, and thank you very much, Karen, for the invitation. Can I just, first of all, just have a show of hands for the people who've heard of the term implementation science? Okay, so a few of you have heard of it. I suppose you're all experts in implementation. Implementation is what you do every day, but there is a growing body of evidence and literature around what helps to make implementation the best it can be, and how can we implement things effectively in a variety of different settings and contexts. So that's some of what we want to share with you today, but we also want to have quite a bit of space for us to work together and to collectively look at implementation and what works in your settings, and to think about how we can improve implementation of these two national guidelines across the variety of the settings. Okay, so we're going to do a very quick overview now of implementation science, and then we're going to get you to work in terms of looking at implementation in your settings and thinking about what helps, what hinders. We're then going to have a break for lunch, and what we're going to do then is we're going to map all of the feedback that you give us to some of the theory of implementation. So there's a lot of theory around what helps and what hinders implementation. But more importantly then, we need to think about, well, what strategies can we do? Once we know what helps, what doesn't work, what's challenging, what are our pitfalls, what are the types of things and strategies that we can do to try and overcome some of these in our settings. And we're going to finish off then with just some group work again, thinking about some action planning for what you can do in your settings. And it's really, I suppose, building a shared responsibility for implementation. So Karen briefly mentioned the Centre for Effective Services, where Mary and I work. So we're not-for-profit, we're mainly funded by government departments and agencies, but we work across a variety of contexts, so we don't just work in health contexts, we also work with children and families, education, justice and community services. But what we do across the variety of settings is very similar. So we do work around innovative service design, using evidence to inform service design, and also support implementation, so both in policy and practice. Okay, so just to explain the term implementation and implementation science a little bit more. So implementation science is a fairly new discipline. It's only in the last couple of decades that this kind of body of evidence around implementation science has emerged. But really, at its simplest, implementation is about getting something into practice. You'll see here this definition refers to it both as an art and a science, because there is a science behind it, there is evidence and a body of literature around what helps implementation, but it's also an art. We work in such a variety of different contexts, and things need to be tweaked in terms of how we implement across these settings. And it's about getting something into our service settings in order to benefit clients, in order to benefit patients. And I think Minister Harris said it well in terms of what he said this morning. It's around putting guidelines into the real world. So we know what best practice looks like. We know what the evidence is telling us. How do we actually get that into our settings and into the real world? So that's really what implementation is about. And implementation science then is simply the study of how that happens. We have a proliferation of kind of what's the best evidence. We constantly research emerging. We know that if we replicate it in other settings, we are likely to see these outcomes being achieved. So how do we do this is what implementation science is about. It draws on a lot of other disciplines. So you'll have heard of things like medical sociology, communications, organizational change development, quality improvement. All of these disciplines share very, very similar ideas and concepts. So the language is a little bit different. So for example, in quality improvement, they both share the same goal in terms of improving outcomes for patients. Just the language is slightly different, but I'm sure a lot of the concepts as we go through them will be very familiar to a lot of you. I think we can see a growing interest in implementation science, and that can be seen increasingly. Grant proposals, funding bodies are increasingly looking to incorporate a component on implementation research. So we can see a growing interest in it. I like this idea of thinking about implementation in terms of a continuum. So here we have diffusion on the left, and this is simply letting it happen. So this is the passive spread of new practices. So we might do a study and find something's effective, and we might publish a literature review, we might publish an article in a journal, but we're not really getting to the people who we really want to be implementing these findings through that method. Hopefully someone will stumble across it, someone will be doing some research, will be looking at some of the latest evidence, and they might decide to take it up in their practice. So it's quite passive. As we move through the continuum, we're looking into more active and planned strategies around getting something into practice. So we're looking at dissemination, which are actively promoting something. So for example, workshops such as today, bringing people together, sharing of information, communication. These are all active strategies that we do to try and get something into the system. And then at the end of the continuum, we have implementation. And implementation is actually the process of actually integrating something into practice. So it's not enough for us to know about something, it's not enough for us to know that it's effective. We need to do some activities, strategies around actually integrating something into a given setting. And why is it important? So as I said, there's a proliferation of evidence, proliferation of research on a daily basis around what's best practice across a whole multitude of topics. But actually getting them disseminated, getting people to take up new practices, new ideas, adhering to them, so using them with fidelity, are real significant challenges. So it's a timely process, it's a challenging, it's a complex thing. It's not easy to actually get something changed in practice or to introduce something new. And there can actually be a lag of about 20 years before we see something published in the research literature and actually to see it being implemented as standard practice. And there's a huge recognition that we need to be paying more attention to implementation. Researchers now have become really concerned with how do they get across messages to the various different stakeholders. So it's really becoming more acknowledged as an important issue, but unfortunately we don't always have the tools and the resources available to us to actually support implementation. And even when we dedicate some time and effort to thinking about implementation in our settings, we don't always have the resources that we need to do it. So for example, we may need to do some training for staff if we want to introduce a new practice. We may need some new IT data systems. We may need some new equipment. We don't always have the resources to do that. Oftentimes, we are trying to work within existing resources. So these are significant challenges for us in terms of trying to put something into practice. And this cartoon, I suppose, really demonstrates that issue. On the left, we know that something works. We have an equation worked out. Someone's done some research to figure out what's best practice, what's going to work to improve outcomes. And on the right, we have our service system, and it's kind of almost, it sometimes feels like it's almost a miracle in terms of how something's going to happen and how something's going to get put into practice. And implementation science is really about trying to demystify this middle box here, this miracle that occurs. And what are the types of strategies, activities, the types of pitfalls that we need to avoid when thinking about how to get something into practice? That's what implementation science is about. We know from the research, the evidence from experience, that we can't just decide to implement an effective practice and get the outcomes that we want to see for patients, for service users. We actually need other things in place. So we don't just need the practice itself. We also need effective implementation methods. And we also need enabling context. I'm going to say a little bit about those two boxes in a moment. This is what we need in order to achieve outcomes. The intervention in itself isn't enough. We can't decide to do something. We also need to really carefully think about how it's implemented. So for example, we need everybody to know about the best practice. We need to be able to communicate effectively, engage effectively with practitioners, professionals, a range of stakeholders. And they may need some training, they may need some resources. And I think there's been some really nice examples where some resources have been put in place, like audit tools, patient leaflets, etc. So we need access to all of these things, but we also need an enabling context. So things like leadership. Does management support this new way of working? Culture, values. So for example, something that's about patient-centered practice, is that a value? Is that valued? Is that a priority within the setting in which we work? And then there's a whole load of other things in the external context, as policy, regulations, etc., that all have an influence. And as healthcare practitioners, we work in such multifaceted contexts. All of these factors have a huge range in terms of whether something works or not in practice. So I think this slide really sums up what implementation science is about. We know we need to do certain things in order to achieve the best outcomes for patients. But we also need a lot of other things in place to support us to do that. And there's a whole range of ideas in the literature around what can help to achieve that. I think Minister Harris said a nice phrase this morning, which sums this slide up, which is that guidelines are only as good as their implementation. I think you really hit the nail on the head with that. But also, we also need to work to build this enabling context. It's not always there, and sometimes some of our implementation strategies is about developing that and building that enabling context. So there's a lot of new terms there in terms of the implementation science and thinking and literature, and I think all of you are used to being bombarded with lots of new terms and ideas. And there's also, to complicate matters, over 100 implementation science theories, frameworks, models. Not very helpful. And some of the recent work that's been done by researchers in the implementation science field is to try and consolidate that a little bit and try and standardise the language that is used. So we are primarily drawing upon two frameworks as we talk today, which is the Active Implementation Framework and the CFR, the Consolidated Framework for Implementation Research. So we'll be drawing on those two mainly today, but there's lots of similar ideas and concepts across all of the frameworks. So there is a growing consensus that there are some core elements of implementation that we see time and time again emerging in the implementation science literature, the theory and the evidence. And we're going to focus on two today. The first is the notion of implementation stages, and thinking about stage-based implementation. And the second is enablers and barriers. We're actually going to spend most of the day today thinking about enablers and barriers within your given settings. And then at the end, thinking about some strategies to try and overcome some of the barriers that are there. So firstly, stages. So we think it's really helpful to think about implementation in terms of stages, and it helps to guide the type of work that we do as we move through the implementation process. So implementation isn't an event, it is a process. And we move through it. Now, we don't always move through it in a linear way, which is why you see the circles here are overlapping. And sometimes we can be in multiple stages at once. But this way of thinking, I think, helps us to diagnose where we are at in terms of our settings in implementing something, and also what are some of the activities that might be helpful at that stage for us to improve implementation. I'm just going to say a little bit briefly about each of these stages. So the first stage is exploration and preparation, and this is really about looking at needs. Philip talked about some of the evidence that we have around patient needs. And it's also about looking at the evidence base for what's best going to meet these needs, what's best going to achieve the best outcomes for patients and service users. We're also looking at the fit and feasibility. So maybe in another country, something has been trialled and proven to be effective, but it may for some reason not work in our health context here in Ireland. So assessing fit and feasibility of these evidence-based practices is also very important. At the end of this stage, we have selected what we are going to implement. So you could say in the instance of national clinical guidelines, it's when you've completed your guidelines. So you've made a decision on what are the best practices, what are the best interventions and recommendations that we are advocating across all of our settings. So there's a lot of work that goes into that, and there's a hugely rigorous process in terms of looking at that for national clinical guideline development. The next stage then is planning and resourcing. So we've decided what we want to implement, and now we need to plan and resource how we get that into practice. Things that can be helpful during this stage is having an implementation plan, a project plan, something that shows all the activities that are going to take place, the timelines, and most importantly, who's going to be responsible for that. You might need to secure some funding for some infrastructure that you need to deliver particular recommendations. Having a team in place in your setting can be really helpful to guide the implementation process. So an implementation team in the implementation science language, or it could be practice development team, quality improvement team, basically a group of core individuals that can look at implementation in your setting and guide it. A key activity of them will also be to look at data, collect data and look at data that's emerging to inform continuous improvement. You might also need to deliver some staff training. They might need some support, some materials. And here is where you're designing your monitoring and evaluation systems. So putting in place your audit system. So before you begin to implement, ideally you would be putting this in place so that you can collect data right from the outset. So then we finally get into stage 3, which is actually implementing something. So a lot of work has to happen before we get to this place. And this is simply when something's delivered for the first time. The first time we use a particular practice or a new change in terms of how we deliver healthcare. Some key activities during this stage are thinking about ongoing professional development and coaching for staff. There's quite a bit of evidence in the research literature that training in itself isn't sufficient in order to change practice, that we need other supports for staff, things like coaching and mentoring, things like communities of practice so that people can come together and share learning with one another. So big evidence behind the need for ongoing support. We also might have new staff that are joining into new settings, so we always need to be thinking about supporting those new staff and providing the ongoing support to existing staff. We also might need to look at the system, the culture that's there, and work to change that. So sometimes a new practice, a new intervention can challenge the existing culture, can challenge the existing system. So we need to be paying attention to that and looking at what we can do to help change that. Are there particular stakeholders that are blocking this that we need to be engaging with and trying to get their buy-in for a new practice? Monitoring ongoing implementation is important as soon as you start, particularly because there can be some tricky periods when we first start to deliver something. And also something that's worked in another setting might work exactly the same in another setting. So we might need to make some tweaks, but we want to be doing those tweaks in a very informed way. So not an ad hoc way, not a kind of an ad hoc decision, oh, this isn't really working, we need to change this. We want to have some data to back up why we might be making some changes and what changes are needed. And talking to staff, people who are delivering them, is really important. So having feedback mechanisms that we can get evidence from the front line, feed it up, but also feed the data back down, and so that we have this continuous feedback and communication loops that are happening. So full implementation is the last stage of implementation. And this is when we get something embedded in practice. So it becomes routine, it's the way of working, it's not new anymore. It maybe doesn't need the same supports and infrastructure required to support it as it might have done in the early days. But a key activity here is around engaging in continuous improvement cycles. So there's always things that we can learn, and I think the experience of the audit showed that there's always data that can tell us, experiences that we can share with one another that can help us to improve. We want to be assessing fidelity and outcomes here as well. So we want to assess implementation. Did we implement as the recommendations told us? But also, what difference is that making? So is that making a difference in terms of outcomes? And that's why I think that, I suppose, the continual collection of data over time can help us to see that, and are we making a difference? So that's very motivating for staff to feed back to staff, and so that they can see that the changes are making a difference to patient outcomes. As I said, we might make some tweaks in terms of the infrastructure. We might need all of the support that we had initially when we started set up. So unfortunately, it takes quite a bit of time to get to this stage. And the evidence shows us it can take 2 to 4 years before we get to this stage of where something is fully integrated in practice. We can't skip stages. Now, in reality, we do. We work in contexts where we're forced to get something into practice straight away, and we don't have the luxury of going through some of these earlier stages of implementation, the planning, the resourcing, the stakeholder engagement. But there are things we can be doing concurrently. So even if we have to move ahead and deliver something, there are other activities from earlier stages of implementation that we could still be doing in the background that we know from the evidence will actually help support implementation. We also need to revisit the stages as new staff, communities and partners become involved. And also we need to continually go back to stage 1 to look at patient needs. So patient needs change, which will inform the types of practices that we do. So that's something, I suppose it's a continuous cycle, and it's a continuous cycle of improvement over time. So that was a really whistle-stop tour through one of the kind of really key components of implementation science, which is in terms of thinking about it, implementation in terms of stages. We find this really helpful because we find it really helps to plan implementation and also guide implementation activities at various stages. We're now going to move on to the second core idea that we want to talk about today, which is around thinking about implementation enablers and barriers. We're going to hand over to you in just a moment, and to set up that group work, I'm going to hand over to my colleague Mary. Thank you.
So I'm told the temperature in the room here is set for a comfortable 18 degrees. Does that mean the temperature in the room is right for the work that we're doing? So what might be the other sources of data about the temperature that I might use? So I'm looking around and seeing a lot of scarves on and quite a few coats on as well. So I'm using that example to draw your attention to the combination of things that we need to be paying attention to in order to inform and guide our decision making. And all of the presentations this morning, from the Minister on, have really drawn attention to, you know, really good initiatives, really important that we have new things emerging, but don't forget about this, that, and the other thing. I was recently in the Commissioners of Irish Lights in Dún Laoghaire. Anybody been out there? So they mind ships going around. They take care of lighthouses and keep lights shining, and these are the navigation devices that keep shipping safe in Irish waters. Very complicated. And increasingly, there are multiple new techniques and technologies that can inform shipping. Satellites, radar, you know, systems for displaying where you are and where other people are on screens in front of you. So increasingly, people in ships spend a lot of their time with their heads down, looking at screens, okay? So the Commissioners of Irish Lights call this heads-down navigation. Okay, so in your world that might be, what's the scan showing? What are the test results showing? What kind of concrete data? You know, very often quantitative data that doesn't require me to interpret too much. There's a kind of an absolute that tells me absolutely where I am. The Commissioner for Irish Lights, this is wonderful. It's a huge advance and has increased shipping on the world's oceans enormously. However, people still need to look out the window and see what's happening in the real world. We call that heads-up navigation. And I was thinking when Evelyn was talking this morning about the need not just to see what's happening in the chart or the test results, but actually to look and pay attention to the patient and say, how are you? And how's this experience for you? So repeatedly this morning we were hearing about how unique and individual the journey is. And that's about developing the capacity in the system to move between those sources of data. And that's essentially what implementation is about. So Aisling has described this morning the science, the new evidence, the new learning that we're discovering about combining experience of implementing things in lots of different fields and what we're learning about that, about what helps and makes it more likely, shifts the odds that things that we know are good for us, like the things that are described with great rigour in the guidance and guidelines that we're talking about today, but how those land in individual, unique, particular settings. So we're going to spend from now until lunchtime thinking about your actual, real, specific, unique settings. So translating that notion of the high-level principles about how you go about implementation and how you think about how you're going to move from where we are now in terms of implementing this guidance and guidelines into where we want to be. And what's actually going to need to happen in your real life situations with the actual people who are there and some of the gaps that you have as well. So Ashley talked about the missing resources. So none of us are working in ideal situations. That doesn't exist. So the perfect setting for making use of this guidance does not exist. But we can shape, exploit, make use of the resources and the motivation that does exist in those resources, in those settings, in order to move forward. So you have all of this in your setting. We're going to ask you to think about implementation in your actual setting. So the first thing we're going to ask you to do at your table is to share the experience, because you're from mixed settings. So I hope that many of you are not here by yourself from your setting, but that you have other people from your setting, and that would be useful as we move on through the day. But to share what stage the implementation of this guidance and these guidelines are in your setting. So we're interested for you to share with each other who knows about these, who has heard of them. So before you go back today and carry these guidance and this helpful resource with you, who in your setting already knows about this? Who cares about it? Who's waiting for you to come back to today with an interested perspective and is expecting something to happen as a result of what you learn today? Who might be a bit afraid of what great ideas you're going to come back with after today, and what the latest enthusiasm is that is going to land in your particular setting? So what has already happened? Where do you think things are now in relation to the implementation of the guidelines in your actual setting? So be as specific as you can in this. Next thing we want to ask you to think about is Anne. So Anne is a clinician in your setting. And I want you to picture an actual person who's in an actual role and an actual job. Again, I was thinking about Anne this morning when I was listening to Evelyn. So when Evelyn said people were able to listen to different things at different times, I was thinking that's absolutely true of patients, but it's also true of staff. It's also true of us. So we're more able to hear and listen to particular times when somebody has thought about, am I completely overwhelmed at the moment, or is there some space for me to be able to take this in? The second parallel, I thought, with what Evelyn was saying, when Evelyn said that her thought, which I think she probably didn't say, but her thought sometimes in consultations was, do they think I have nothing better to be doing than to listen to them? So I don't know about you, but I've been in some settings when somebody has been offering me great richness of information. And I will admit that sometimes the thought has crossed my mind, do they think I have nothing better to do but to listen to them and to apply all of these wonderful ideas? Because, of course, Anne, as a clinician, has to integrate this with an already busy, overstretched job managing multiple priorities simultaneously. So when you start to think about Anne and think about what does Anne need? So the implementation of these guidelines doesn't just depend on you. It doesn't just depend on additional resources. It depends on Anne and Michael and Mary and all of those people already really busy doing the very best they can and getting up every day to do the best job they know how to do. So how is it that you, in your setting, are going to offer these guidelines in to Anne in a way that means that she can access those and change her practice to reflect the guidance? So I'm going to ask you to think about what Anne needs at an individual level, at an organisational level. So in your organisation, what would need to be happening differently, what would need to stop happening or start happening, that is actually going to support Anne to be reflecting the guidelines. And then at the wider system. So there's stuff that happens at an individual level, stuff that happens at an organisational level, but all of those exist in a wider system, and we refer to that a number of times today too. So you need to be thinking about what will support Anne and what will get in the way. And when we ask you to report back, so the first thing I'm going to do is ask you to divvy up the work here. So we'll ask somebody from each table to give us some feedback when we come back together at about 5:30 or maybe 25 to. And to hear at each. So we'll ask some tables to tell us what did you think needed to happen at individual level. We'll ask other tables to say what did you think, what's your advice about what Anne means at organisational level and so on. But basically at each table you need to be thinking about all of those. I'd encourage you to use this time and this resource. So you have people at your table now who are a resource to you. When are you going to get half an hour with this many interested, motivated, skilled and experienced people thinking about helping to implement these guidelines in your setting? Okay? So be absolutely selfish and ruthless is my advice to you. We'll attempt, if fights break out, we'll attempt to mediate it. We move around doing. I'm just going to ask you to undertake this. You have a page on your table in your plastic folder for this. We're going to ask you to start by sharing the experience of where you think the guidance are at. Ashley and I will move around the room, shout if you need any help, and we'll come back together in half an hour.